Yeah. Yes, okie doke then, right. Okay, so
is everybody aware that this is being recorded?
yeah, you're all happy that it's being recorded?
Fine.
Yeah.
Thank you very much.
No, Paul Shepherd says no.
I'll just have to be careful what I say.
Yeah. So what we'll do, intro. So yeah, a very warm welcome to the Summer Valley Forum. And for any of you who don't know me, but I think you all do, I'm Linda Robertson. I'm the chair, and obviously Ron here is vice chair. So I think most of you know both of us. So on we'll go. So for anyone, is it the first meeting for anyone? If it is, then we hope you'll find it of some value. And I need to remind everyone to the rules. Okay, keep background noise to a minimum, please. To only speak one person at a time and not to speak over others. Please mute your microphones when not speaking, and then unmute when I invite you to speak. And please indicate if you wish to speak by putting your virtual hand up, and I'll call you in turn. Please also type your name in the chat so that we have a record of who is attending. Okay, we do have apologies. Alistair Slade, Councillor Sean Stevenson McCall, Councillor Grant Johnson, Councillor Liz Hardman, Peacedown St John Parish Council, and PC Mark Graham, who we had hoped was coming, but Paul Shepherd has replaced him. And we do have some updates for you during the evening. So I'll hand over to Ron now, and he'll take over the next section.
Okay, ladies and gentlemen, and our newborn babe friend. Well done, Becky. We're going to talk, first of all, I've got a couple of things I'm going to talk about that I know very little about, so I'm hoping we'll gather speed as we go along. First one is Summer Valley Links. The Summer Valley Links project seeks to provide improvements to public transport, walking, wheeling and cycling along the key corridors of the A37, A362 and the A367. Information was shared with the forum in July 2023 as part of a wider public engagement exercise. The results of this have been published, and we will share a link about that for that and after the meeting. The West of England Combined Authority, I love saying WECA, has now developed the online business case OBC for the scheme, and this was considered at their committee meeting on the 26th of January. They agreed to approve the drawdown of funding to develop the proposals in more detail, including production of a full business case, FBC. It was also noted that going forward, further development of the project would be led by Baines rather than the combined authority. The commissioned consultants are currently updating and refining the proposals. The revised proposal will be considered at a further public consultation event later in 2024. Potentially, that's this summer. A fuller update of the City Regional Sustainable Transport Settlement Programme will be circulated after the meeting.
Okay, so we're now looking at the local plan, and the local plan option consultation opened on the 12th of February and will run until the 8th of April, so we've still got a bit of time. Local plans are at the heart of the planning system and are the main consideration in deciding planning applications locally. So it's important people have their say at this stage in the process. There will also be a series of drop-in sessions where people can discuss the options with council officers. Hopefully some of you attended Radstock's drop-in yesterday. Did that happen, George? Yes, good. And there is also one at the Hive in Peacedown this Friday, the 1st of March, and one at Farrington Gurney Village Hall on the 13th of March. And we will circulate information after the meeting. So, Ron?
Okay, we'll move on to the second subject that I know very little about, except some of the horror that it caused when it was originally raised, the West Local. You may have read in the local press that Poulton Parish Council have been successful in their bid to WECA for West Local. This is a scheme which allows communities to access cash to design and run their very own not-for-profit bus. Poulton West Local will link communities across the Somer Valley and Cam Valley, running from Radstock to Old Odddown, Park and Ride via Westfield, Midsummer Norton, Poulton, Radford, Timsbury, Camerton and Tinley. This service will run 5 times a day starting in the spring. Very quickly, that is. Councillor Hardeman had hoped she would be able to give us an update in person this evening, but she's been called away at very short notice. And excuse me a moment. However, she will be providing a written report, and we will circulate that after the meeting. That's a very important step forward for a lot of people in this area.
Yeah, too right.
Okay, I'm staying with you now for the next step, the police and fire update. I'm going to introduce to you, never mind the others, I'm going to introduce Paul Shepherd, who's our new man. I'm a Westfield councillor, so he knows me. Don't be frightened. Hang on to the arms on your chair and go ahead.
Good afternoon, everybody. Good evening. Yeah, just to let you know, my name's Paul, new beat manager covering Westfield. I've been tasked with this evening, this meeting this evening. It's my first one, so a little bit of trepidation here. Been a police officer for 20 years. This is my first meeting, but basically I've sent Alison a report with the Somer Valley crime stats for the last 3 months. They've actually 42 in the previous 3 months. They've gone down by 42 reported incidents. I mean, obviously, it's all looking good at the moment. ASB is also down, I believe, by 65 from the previous 3 months. So it's all looking good at the moment.
Oh, brilliant.
Paul, did you say it's down by 65%?
No, 62 recorded incidents, not 65%.
Okay.
62.
I was going to say that's okay.
That would be amazing if I could have done that in the 3 months I've been here.
That's why I asked. Stop you. Yeah, okay, fine.
Yeah.
Yeah, that's where we are at the moment. Obviously, like I said, it's my first time. PC, I was meant to be here as an observer, but PC Graham's decided to go off on holiday and left me holding the chalice, shall we say? If anybody's got any questions for me, by all means, Alison will have my details. If not, you can find them on the website. And like I said, I've sent the crime stats out. So, Alison, if you can send them out to people after the meeting, that'd be amazing.
Okay.
Yeah.
Can I make a comment, Paul?
You can.
An important thing that it's to do very much with beat officers and that kind of thing. The A367, which is the big road that divides Westfield into its 2 component parts, has long been used by people like McLaren and Ferrari for track testing their Formula 1 cars.
It has.
And the downhill sections make it very difficult to enforce. We had lots of policemen on lay-bys, and in fact, there's a policeman on a lay-by on a motorcycle in front of my house quite often. But we've done something about that now, and the police authority have one of their grants, and through Baines as well, Baines Attention to Detail, we will now be installing 2 speed indicators on the A367 at key points. We'll be talking to Paul about other things, about where they should be and that kind of thing. But it's an interesting point to say that money was forthcoming, and it was forthcoming very quickly. We're very, very, very grateful. Thank you very much for that.
No problem at all. Thank you.
Any questions?
Anybody else? Lavinia.
Can you still hear me?
Yeah.
That's fine. It's just that sometimes when recording starts, I have a problem. Now, I've got a couple of questions for you, Paul. Very nice to meet you. I'm from Radstock Town Council. My name is Lavinia. And I just wondered if you had any information regarding the trends in the Somer Valley in terms of the breakdown of different types of crime. And also, you mentioned that these were incidents. These are your incidents that you've dealt with, they're not the British Crime Survey figures. Is that correct?
Yeah, these are obviously reported incidents to us. So some of them are crimes, some of them aren't. We don't know if we're going to get a conviction at the end of it, but potentially these are reported incidents at the moment.
And the other part of my question about trends, I mean, can you see a difference in some of the trends, for example, on assaults or drug problems, or over the last couple of years rather than the last couple of quarters?
Like I said, I'm new to this. This was my first first time here. Trying to collate these statistics. So what I will do, I don't have the answer for you at the moment, but I can go back and look into that.
That's brilliant. Thank you very much.
Yes.
Right then. Does anybody else have a question? Yes, Eleanor.
Yes, we have a problem in Westfield with persistent vandalism, especially on the West Hill recreation ground. But yesterday, the new Westfield in Bloom floral display was vandalised. This is in Shakespeare Road. So I asked the residents, have you reported it to the police? Did you see anything and so on? They said, oh no, we never see a policeman. There's no point. I mean, is that a common attitude? Is it a problem dealing with minor acts of vandalism?
No, it's not a problem at all. We can always go out and deal with it. But if we don't get a call, we can't respond to it. So if they've not called us, we can't respond, can we?
Well, this is a problem, you see. People know how thinly stretched you are and are worried. Well, they just think you won't do anything about it, whether that's fair or not. It probably isn't. But what can we do to restore the residents' confidence in the police is my question.
Well, when I'm on duty, I do tend to go on foot patrol up around in Westfield, probably 2 hours a shift. So, I mean, like I said, I'm quite new to the role. But I'm doing my best to get out and about and be seen up there. It might be that
And
we've just
you are, Paul. You are seen.
So, like I said, I'm doing my best out there at the moment. My PCSOs are out as much as they can be. So, yeah, we'll keep doing what we're doing. But if people have issues that are arising, as I've said, if they don't report it or let us know, we can't react.
I mean, one problem I always had is when I've reported a crime or some antisocial behaviour, trying to get through where Westfield is, because you're talking to Portishead or somewhere. Midsummer Norton is even worse because they think it's connected to Midsummer Norton, the Midsummer Murders. You have to explain, no, that's a fictional place and it's usually shot in Corsham and it's nothing to do with this town where there's a problem of whatever it is.
Yeah, like I said, I understand that, but if people are going to give out the correct postcodes, and they also use what 3 words in a lot of cases, if people are using that, we can get directly to where the issues are. But like I said, they need to report it to us.
Yeah, can I just clarify that position a little bit? One of the issues, and I see Tim Orange here as a guest, that Baines is also addressing in conjunction with Westfield Parish Council and to a degree Midsummer Norton, is that the post office consider the area to be one big postal town: Radstock, Midsummer Norton, and Westfield. In fact, even Chilcompton is in the Radstock postal town area. So people get very confused. And when the situation was broken up into the 3 separate councils now that it was, instead of the old Norton Radstock situation, it became a bit difficult because, for example, and this is not meant to aim at Paul, the Radstock police station, as it's called by all the officers, is in fact in Westfield. So it's very confusing. Your office, Paul, is in Westfield. And the Bath College, for example, is in Westfield. If you see the press, they'll say Radstock. So it's very confusing for everybody. And, you know, so we may need to make sure that we tell as many of the population as possible that they live in 3 separate areas and the postcode is vital. Okay, thank you.
Okay then. So thank you very much for Paul for coming along and having a chat with us. Hopefully I'll see, as I come from Midsummer Norton, not Westfield. I won't see you while you're on duty probably, but I'll see you again some point. Thank you.
Thank you very much.
Okey-doke. Okay then, now so we're going on to section 3 here, which is health and well-being. And we'll now have a series of updates on our main theme of health and well-being. And our first presenter does need to get away, so we'll take questions after his presentation. So a very warm welcome, please, to Nick Applin, who's a specialist frailty nurse serving our local area.
Lovely, thank you very much, and apologies that I have to go. I kind of stepped in and got some childcare responsibilities this evening, but thanks for inviting me and letting me speak. Not quite as little as down there. So really appreciate you letting me chat with you. I think what I'd like to kind of perhaps help or support is some of the BSW things that we're trying to achieve around health and frailty, some of the local things that we're doing, and some of the ways perhaps that you could think about how you could support us in those goals as well. And I think when I talk about frailty, it's not a word that everyone likes. It happens to be the word that people use in research, but it could be aging well, or it could be older people's care, but it covers quite a wide remit. So bear with me kind of while I'm talking about it. And if I use the word frailty, it's just because that's kind of the accepted terminology at the moment. But yeah, it's not appreciated by everybody. So I had a few slides, Alison. I appreciate... I'm very happy to take questions, and also I'll put my email address in the chat, because you're very welcome to catch up with me on that thing at some point as well. So the reason we like to talk about frailty on the next slide is that actually if we can start to identify people perhaps who are starting to become more vulnerable, we can actually start to identify in advance what we can do for them to prevent there being an adverse event, basically. So things like falls or admissions or anxiety, depression, things like that. So that's just to give us an idea of why we can talk about frailty now. And there's been a lot more evidence and a lot more information around interventions that are effective and things that we can do, which will be, I suspect, you'll recognise, because a lot of it is relatively common sense, but we've managed to kind of put it together and get some evidence. Thanks, Alison. So when we're talking about frailty in a kind of health sense, it's around people losing muscle mass, perhaps losing strength, mobility, and some of those things there are the things that we might recognise. So a change in continence, falls, low mood, people losing weight, losing appetite. And I suspect, though, that you would recognise people who are living with frailty just from your experience and from working with those people. It is different from people that just have a lot of ill health, and you don't necessarily suffer from frailty as you get older. So lots of people can age well and never hit frailty. So we're talking about people that are becoming vulnerable to illness, disease, and are maybe becoming slower and generally more vulnerable to any kind of insult, really. Okay, thank you, Alison. So this is what we're trying to aim for as a BSW-wide frailty pathway, which is quite wide-ranging, because this ranges from people who haven't yet been identified as frail or become frail, all the way through to people that maybe are living with severe frailty in, say, for example, a nursing home, or can't get out of the house. So it is quite a wide-ranging pathway, but these are the main areas that we could do with support with, and I'm, community services. Some of them are led by hospitals. Some of the people that are more unwell may be led by care homes, but there's an awful lot that can be led by voluntary services, council, and already is led by a lot of those services. So we need to identify frailty. We need to assess that person well, develop a personalised plan, then carry out the interventions, see whether they've worked or not, and then have some kind of ongoing review. Thanks, Alison. And I'll kind of break that down a little bit. So 2 things that could be really helpful is just people understanding what frailty is. And I've put loads of links at the end, but people understanding frailty and knowing how to refer, or even just recognizing in the first place, is actually would be a really helpful step. So there's individual training that people can do there on e-learning for health, and there's also things around workforce planning. So if you are setting up services or new roles or job specifications, that workforce heading actually gives some insight into what kind of characters we would expect from somebody to manage people with frailty, all the way from taxi driver or dial-a-ride, or people that maybe just may meet people who are starting to become frail, and then that training goes up to people like geriatricians or specialists and everyone in between. So there's quite a wealth of information in there. And the last one there, the Rockwood Clinical Frailty Scale, is what we are suggesting that people use in clinical areas to try and identify frailty. And if we go on to the next slide, it might just help to give you an idea of what we're talking about. So this is the Rockwood Clinical Frailty Scale, very commonly used. It is a little bit kind of a quick aid, but we're better off identifying as many people as we can, and then perhaps if we do an intervention or an assessment and it turns out we've given them more, that's better than not recognizing people and then falling through the gaps and ending up in all sorts of a pickle. So we're looking at managing well and vulnerable, which is Rockwood 3 to 4, all the way through to 7, which is kind of care home, and then we've got people that are towards end of life in Rockwood score 8 and 9. It's only a very rough kind of idea, but we're trying to get this kind of into GP. Well, it is in GP practices, hospitals, but and ambulance services, but just trying to get people to recognise it a bit more. Okay, thank you. Once we've identified someone, depending on the level, a comprehensive assessment, and this is also a bit of a change. So initially, this has been taken on by GP, and I know we've got a GP, Helen. Hi, Helen, on the call as well. A lot of these things were taken on traditionally by medical services, but actually we're trying to move it so that people in voluntary services, people who just work with people who are older, or therapists or other people can actually start to do this assessment. So it's not all medical. What we've often missed out is the things around the psychological support, the environment, and kind of the functional, how people actually manage things. So I think it's worth saying at this point that actually I think that in Baines particularly, I don't know as much about Swindon and Wiltshire, most of these services exist and work really well, and we do have loads of stuff around voluntary services. We have a hospital that caters really well for older people, and there's just loads of skills and expertise in there, but it's not necessarily all put together or communicated or worked together. So there's some themes around how we can kind of join up some of this support, and I'll talk a little bit about the project that we're doing with the Community Wellbeing Hub in a moment. But that's your themes around what you want to do. Now, that doesn't all have to be done by one person and a big review for 2 hours. We've got an integrated care record now, which all medical and the Community Wellbeing Hub is soon to be able to access, where we can actually put all this information and all the little bits that people know about someone, we can put together so we actually get a much bigger picture and other people can see. Because at the moment, if an information goes into the hospital, then it stays there pretty much, and also what the voluntary services know isn't shared with the hospital. So something around like the integrated care record that we have is going to be really helpful, but this is kind of what we're trying to achieve. Thanks, Alison. Interventions, and again, this is just a very rough idea of the things that we can do. So people that are pre-frail, we're looking at kind of maybe council services or statutory services around healthy aging and smoke cessation and things like that. Mild frailty, more looking at kind of that strength and balance, loneliness and isolation and housing. And you can see here how like bringing in all of your services is where we're trying to kind of aim to, so that we're not working in isolation. Moderate frailty is moving more into the kind of medical domain, but obviously there's still a lot of support from voluntary services there. And severe frailty, you know, we're looking more towards kind of focus on symptom control perhaps and end of life, and people tend to have a lot of care at that point. But this is where we're kind of missing, and we're missing that identification really at that pre-frail, because what we're really trying to do is bring in anticipatory or proactive care, where we recognize people in that pre-frail, mild frail area, so that we can actually prevent that progression through frailty to those other things. And what we're hoping is that we can involve fire service, police, counsellors, drivers to actually have a pathway and a process that they can refer into, that we can hit these services early and have a bit more of a joined up approach. Thanks, Alison. These are just some evidence-based things that actually are quite that are, if you recognise people with these, it needs further investigation, or if someone is living with frailty, these are the most likely things that may happen to them, but also have the best evidence base around managing. So we shouldn't ignore a fall. They rarely happen in isolation. If people are getting a bit older, it needs a proper assessment and a proper look at why has that fall happened. Is it around medications? Is it around environment? Is it around eyesight? And all of those things that don't necessarily need to be medical. There may be a medical cause, and that may be an element of it, but I think we're trying to move away from that and actually look at some of the things that we can intervene with without needing kind of to have that as the centre. Things around kind of medication reviews would need to be someone with that kind of expertise, but that's just some ideas of some of the things that we're looking for really with our assessment. Thanks, Alison. These are some of the themes that work throughout. So educating people, people understanding, working together. MDT I'm using as multidisciplinary team meetings, which can mean a lot of things to a lot of people, but essentially it's sitting together in the same room and talking. So the anticipatory care or frailty MDT that I'm doing with the Community Wellbeing Hub, we're actually taking referrals from voluntary services. These are people that live in the community, live in your communities that probably you know about, but haven't necessarily either presented themselves to a GP or have ended up in hospital. And actually we are taking referrals on those and trying to get in there early. And there's lots of people that for one reason or another either haven't presented because they haven't reached a threshold, or they choose not to, or you know, well, there's as many reasons as you like really. So we're getting the referrals from them. So and sorry, I'm kind of going ahead. I know I haven't got long. Sharing information, that proactive care, what matters to you is where we need to start, as in instead of going off on a medical kind of journey, is actually what do you want and what do you want to achieve, and asking that question right at the beginning. Shared decision making, so we don't make plans without, and appropriate care at the appropriate time. So if we can go on to the next step. Sorry, I know I'm ranting too much really. So the Community Wellbeing Hub, this is the thing that we're doing. So we're identifying frailty early. We've got a referral form which outlines a little bit around how you might recognise someone who's frail. We're doing a comprehensive assessment, and we've got Age UK, we've got the village agents, we've got myself as sort of a representative from health, we've got some health coaches and other voluntary services as well, and we are sitting around and talking about how we can wrap the services around that individual. We're going out, and either I'm going out or one of the health coaches is going out and actually meeting that person face to face and spending a bit of time with them to really kind of work through what's needed. Write a personalised plan with them for what they want or their families want if they're unable to make decisions for themselves, and we write a letter to the person rather than writing it to the GP, but I copy it to the GP, and that way they've got a copy in their hands that they can work with. I'm happy to do referrals with people, and there may be a few jobs as well that are medical, so we're trying to kind of include everyone on that. The interventions we kind of refer on if we need to, and then the ONS4 is one of the data things we're trying to use, is the Office for National Statistics 4 questions, satisfaction, anxiety, well-being questions, basically, that we can try and track whether going in and doing these things are helpful, because there is a cost that can be worked out from whether we can improve someone's satisfaction. We can also work out from avoiding a hospital stay, from avoiding a care home and that being funded. So they're not the primary outcomes from doing these reviews, but they are outcomes that commissioners are quite interested in. If I'm honest, from my point of view, we're doing it to improve the quality for the person and their families and the communities, but people like to see that things are cheap or at least cost neutral. So we do have to get some kind of feedback. So if we could go on to the next one, I think we're probably, the frailty pathway for BSW is around understanding all of what I've said, but so that anybody from any area can actually look at it and say, this is what we should do for education. This is who we should refer to. These are the kind of things we should be thinking about for that person, or for that group of people. So that's what we're trying to achieve, and that is going to involve working with 3SG, who I know is on the call, Wellbeing Hub, GP practices, hospital, because to pull all that together just in some kind of understandable framework that we can share, I think is probably where we need to be, using the services we've got more effectively, and talking to each other and sharing information. It can be really powerful, and we found that in COVID. Okay, thank you, Alison. And I'm just going to leave that on the slide, but that's just some ideas, again, about kind of, I understand these being shared later or would be available. Okay, thank you. So you're welcome to email me. Some of that's aspirational, some of that's happening now. The principles absolutely are national and local kind of where we want to achieve things, and so much of it is just about working together, and I think we'll get there. So very happy to talk about it or explain any of the jargon if I've gone off on a thing too much, or any support you've got or any ideas, gratefully received.
Well, I have to say that was really interesting because I didn't know so much about that. So thank you. Does anyone have any questions that they'd like to ask? Yes, Luke Lyons.
Yeah, hi there, Nick.
Hi,
Luke Lyons from Avon Fire and Rescue. So we're doing a very similar thing with Serona Care for South Gloss, Bristol and North Somerset. So be quite interested to talk to you about that and how we can refer into you and you can refer into us, obviously, because the people you're going to be visiting are the people that we need to be logging as people that can't escape unaided, basically, out of their property. So yeah, it'd be very interesting catching up with you at some point. I was trying to find your email address, but I couldn't see it in the chat. But
I will put it in now.
Cool. And I'll email you my details.
Yeah, that would be absolutely great. Thank you. And I have referred quite a few people to you, and we have actually had a referral from Avon Fire as well that was very interesting, and we managed to make some inroads on that as well. Working together, isn't it, really?
Yeah, exactly.
I think it would be useful for your slides to be supplied to everybody who's taking part tonight, and Alison's nodding her head in agreement. So we'll do that, everybody, because this has taken me a bit by surprise.
Yeah. I think, Eleanor, you've got your hand up?
Well, yes, if the slides could possibly be delivered in a form which I can read, because they're not glaucoma friendly, I'm afraid, with that background and that white lettering. And there's too much print. If there's some way to spread them out into more slides, that would be very helpful, because I'm sure it's very important information. But I do have to question whether it's achievable what you're trying to do when it's can be so very difficult to get a GP appointment, and that may be just a phone call. I've got a neighbour who I certainly think is on the scale, but she hasn't seen her GP face to face since the beginning of October. Because she's not got cancer or anything that's particularly critical or likely to affect the local statistics. And then similarly, we're demanding more and more of voluntary agencies and the third sector, but at the same time, we're cutting the grants to them. So, we're going to have more and more people chasing fewer and fewer resources is what I'm afraid may be the outcome, admirable though it is.
So I think there's something around moving things before to actually intervene before people become unwell, but that obviously is quite difficult to do while you've still got people becoming unwell. So nationally, there is more money coming in to proactive care. I think one of the things around if we had a pathway is that not everything has to go via the GP or by the practice. So they do remain the centre of kind of medical records and they need to be involved. But it is easier to have other people like nurse practitioners like myself getting involved with things around managing to triage what's important, what needs a GP, but at the moment they have to deal with all sorts. So, you know, this is an attempt to try and exactly do that, use the resources where they're intended. There's always going to be a scrap about funding, I'm sure. I've got to say that the Community Wellbeing Hub has been absolutely fantastic. And as far as working with groups of people that have been happy to get stuck in, get involved and try something new, they've been absolutely fantastic. So, I mean, I really appreciate working with that group.
Lovely. Tim
Yeah,
Moran?
yeah, sure. Just a little bit of feedback, Nick. I had an experience recently with my stepfather who sadly passed away on New Year's Day, and also my mother, she's nearly 90 now and very frail. And the service we've had has been absolutely 100% excellent. So it is working, and it's been joined with, you know, with nurses, Dorothy House. But I must say, everybody that's been involved has been absolutely fabulous for what it's worth. So thank you for you and your team.
Great, I'm glad to hear that.
Yeah. And Lavinia?
Thank you. Hello, Nick. I'm Lavinia, Radstock Town Councillor, and I'm interested in the work that you're doing, and which I think is absolutely wonderful, with particular reference to people's loneliness and the housing conditions in which they're living. And you know, because your project is looking at, you know, the wider implications of health, you know, have you got any data or reports that you're collating on those sorts of issues?
Yeah, so I mean, the project that we're doing is we've had about 40 people through, 35 people through with the project that I'm doing, because it is being done without any funding to try and kind of prove benefit. Certainly housing comes up quite frequently. I think what's been more helpful for me has been the Community Wellbeing Hub meeting that comes after mine, which is where all the services are supported. So Curo's there, for example, the council is there, all sorts of people like that. So I suspect that Sarah would have better and bigger data on kind of how referrals have moved out. But housing, finances, vision, all of these things, you know, are really important. And We Care as well. We've been using a lot of referrals to either to actually do the work or as a trusted trader sort of thing, if that's not given away a copyright. Yes, environment, housing, really involved. I don't have any big numbers for you because the numbers we're doing is small. I think we're trying to prove benefit, but the Wellbeing Hub, certainly they're a big player. They're missed when they're not there, let's put it that way.
Yeah, I have been in contact with them, and they are doing excellent work. So even if it's, you know, slightly small numbers or smaller than one might wish. But thank you very much for your contribution tonight. Much appreciated.
My pleasure.
Yeah. Eleanor, do you have another question?
Oh, well, I think there's another problem, but maybe I'm just unduly sensitive, being a politician, about confidentiality. I would really be most annoyed if somebody referred me and details and information about my medical history, my status, my income and so on were being passed into a sort of general database, as it seems there might be.
Yeah, so
but perhaps I'm an exception.
No. I mean, these things have been kind of discussed at length. So as far as my project, the Community Wellbeing Hub, then referrals, people are asked, are they happy for information to be shared between groups of people and to be discussed? And when it comes to specific health data, then we get, you know, I call them and we say, like, you're right if we come out and see you and come and see you on this date. As far as the integrated care record goes, there is which is information which is which is across BSW, which is around kind of a summary of health records, is people like social workers, hospital, primary care, being able to see that data, and there is an opt-out to being able to do that. I would say when people have chosen to opt out of sharing that data, you end up working quite blind. And in my experience, for what I'm trying to achieve, it makes it very difficult to actually pull things together. So there are absolutely, you need to make sure confidentiality and consent and sharing rules are all followed. But in fact, sharing data, I think, just makes everything go much more smoothly, as long as you've kind of got that background consent done.
Thank you very much, Nick, for coming, being with us tonight. For me, everybody who knows me knows that I think where would we be without the NHS and all they do? And so thank you very much. And you can buzz off now to wherever you have to go.
Lovely. Thanks very much. Nice
We'll
to
see
meet
you
you all.
again.
Right,
Cheers.
thanks. Bye.
Bye-bye. Okay, then. So move on to the next one. Luke Lyons, who's the Fire Safety Officer with Avon Fire and Rescue, to tell us more about your home safety visits, please.
Yeah, certainly. Can I share some slides with you as well? So
Yeah.
So yeah, I'm just gonna give a very summary, because this talk normally takes about 45 minutes. So this is a very whistle stop tour through.
Yeah.
Like I said, I'm Luke Lyons from Avon Fire and Rescue, one of the crew managers in the Vulnerable Adults team. So our team basically goes out and does personalised home fire safety visits for the most vulnerable in our communities. So this is really to put a bit of a perspective on it. So we cover the whole of Avon. For those of you who don't know, Bath and North East Somerset, South Gloss, Bristol and North Somerset. Approximately 1.2 million people, 490,000 properties. And in that year, we had 554 accidental fires in the home, which the year before it was lower, it was 470, so it has gone up slightly. But we feel that, when you think of how many properties, and if you ask the general population, when we go and do these talks, they come out with like 5, 10, 20,000 fires. And then we explain that, you don't see fire engines or don't see house fires everywhere. So it is quite it's just over one a day. So it is very rare. Unfortunately, 38 people out of that were hospitalised, and 5 people killed and lost their lives. This is the takeaway. 8% of all fire deaths occur in our own home. So when we're in our own home, we're more likely to be involved in a fire death than we are anywhere else. And the main reason for that is because we're asleep. So when we're asleep, we lose our senses. So we lose our hearing, diminishes, our eyesight goes, and our sense of smell diminishes as well. And there's still a number of people in our communities that don't have smoke detectors. A very simple, £5 smoke detector literally can save your life. So we go out and talk to people about the 4 main causes of house fires, which are cooking, electrical, smoking, and candles. And we go through these various topics and explain them all to them. But it's 62% of our house fires start in the kitchen, and this is mainly due to people leaving their cooking unattended. So they'll have stuff on the hob or in the grill with a higher fat content, and then leave that while it's on the grill or while it's on the hob. Answer the door, or answer the phone, get involved with that, and next thing they know, that's on fire. So if we are at our stove keeping an eye on things, especially when we're doing a high fat content, we're less likely to have a fire start there. So we also talked to them about the bedtime checklist and planning their great escape. Number of people don't even think about what they would do if there was an incident. think that I'll leave my keys in the kitchen because that's where I've always left my keys. 62% of all our house fires start in the kitchen. We want our keys, a single key by our front door, so we can put it in the lock, get ourselves out of the house nice and quick when we need to. That needs to be somewhere that people from outside can't see, and it needs to be where we all know where it's going to be within the house, i.e. on a little hook or in a little dish or something like that. So we talk to people about their bedtime routine, making sure we do the obvious, but we don't always do this because that's why we have house fires. So switch off and unplug any appliances. This really is about switching off things, not unplugging necessarily. But those days have gone a little bit. Things are a lot safer in our homes with our fuse boards and stuff. Check our cookers off. We still go to a number of house fires where the cooker was the main cause of it and it was been left on. This is one of the 4 main categories, so candles and cigarettes, making sure they're out properly. People leave them smouldering or just leave the candles on, or lit, sorry, not on. And closing doors. People don't realise the simple act of closing a door can literally save their life. So if you close your kitchen door, which is where most house fires start, you've got a smoke detector in your hallway or on your landing. You should have one on each level. It only takes a little bit of smoke, a little bit of whispery smoke to get to that smoke detector. I mean, if you ever set one off and you've been doing some cooking, you look round, you can't see it. So a little bit of smoke, and next thing we know, that's off. Gives us plenty of time to react and get out of a house in a smoke-free environment. There's a massive misconception that we as humans can breathe smoke. We see it on the telly, we see people running around burning buildings. It's actually only 2 to 3 breaths of toxic smoke within our homes. So the general smoke that occurs when we have a house fire, 2 to 3 breaths of that, and you are unconscious on the floor. That's why it's very important to keep our doors closed. We're going to talk about the keys, make sure they are where we all know where they are. This is why it's important to close doors. So this, that's the landing, or the bedroom, sorry, and that's the landing. So this started in the kitchen. There's a couple more, there's a load more pictures, but basically it started in the kitchen. It travelled up through the hall, up the stairs. The only thing that saved her life was the fact that she actually had that the bedroom door closed. And it was only by the fact that a neighbour saw the glow and thought that's not normal and called us. She was fast asleep in bed when we opened this door. No smoke detectors, and yeah, this door literally saved her life. But if she'd closed the kitchen door, had a smoke detector, she could have called us a lot earlier, and we could have dealt with it rather than being a house fire. It just been a kitchen fire. We talk to people about what to do if they're unable to escape. So go to a room furthest from the fire. Probably going to be the room that you're in, if I'm honest. Most people aren't going to try and venture, especially if it's smoky. Shut and block the doors. So that's basically about putting bedding, blankets, that type of thing at the bottom of the door to stop any smoke from coming in. Open a window, call fire help. There's been some research done around the fact that if you shout help out of a window, people might think that it's a domestic violence, and some people won't get involved in that and will walk on. Whereas actually by shouting fire and then help, there is more chance of you actually getting some help for them. That's if you can't use your mobile phone. Really, this one wants to be a bit further up the list. It's all part of it. So if you call 999 as soon as you've got your fire, we will give you all this, what we call fire survival guidance, while you're on the phone, and make sure you're nice and safe. The reason we ask you to stay by a window is because when we get there, we do what we call a 360. We go around the outside of the building, ascertain where you are, make contact with you. We might choose to put a ladder up, or we might make our plan straight away we will go in straight away and put the fire out, and then we probably will bring you back down the house if it's not too damaged, rather than bringing you out on a ladder. It's not the best place to be out on a ladder. This is the little fact we spoke about earlier. 2 to 3 breaths of toxic smoke and you're unconscious. So what we tell people, don't try and tackle the fire yourself. You're the only thing in your property that can't, excuse me, that can't be replaced. Everything else is replaceable, unless you're very fortunate to have a nice Ming vase or a Turner painting or something like that. So yeah, you're the only thing that can't be replaced. Raise the alarm as soon as you can. If it's safe to do so and you can, get everyone outside and call 999. So the other thing that we do is we get people to test their smoke detectors. We go through that, how to test them. As the little diagram here shows, one on every floor, and then testing it. We should be testing them at least once a month, ideally once a fortnight when we put the bins out, and that gives us the least amount of time in between. So if they aren't working, then we can get that rectified. So here we go. We offer free home fire safety visits, and we'll fit smoke alarm equipment. So some of our equipment involves. So that's some of the criteria. Basically, if you've got children under the age of 5, you automatically, no, you don't automatically, you have to apply for it. But we'll come out and do a visit. You qualify for it. And if you're over the age of 65, and this is where we've taken statistics. So we've taken those statistics, we've looked at that, and we've gone, right, people with children under the age of 5 are more likely to have a house fire, and people over the age of 65 are more likely to have a house fire. And then obviously we've got a criteria, other concerns in between. Right, so we provide all that equipment there. So deaf alarms, linked alarms, so the linked alarms link to the deaf alarms. We offer carbon monoxide alarms. We offer fire retardant bedding and fire retardant spray, lockable letterboxes, and that's from threat of arson. And we offer dementia bands as well. The dementia bands are a yellow band that basically we program that band with your name, next of kin's telephone number, your date of birth, roughly where you live. I understand the issues listening to the call earlier where we might say we are, whether it's Radstock, Westfield, or whatever else it was you guys said. So yeah, we put a rough area just so that we can then realise that if you're in London, you're completely in the wrong place. So you might have got on a train or got on a coach because that's what you used to do to go to work, and then suddenly you find yourself in Bristol or wherever it might be. That's all completely free of charge and all done through our referral, and I will put the link in there for you guys so that you can share that with other people. Are there any questions? I will stop sharing. One thing I would say is that currently Bath and North East Somerset are not as good as other counties at referring through to us. You're probably one of the lowest areas of referral, so that either means you've all got smoke detectors and you're all fairly safe, or you either don't know about it, or I don't know what the other issue would be. Sorry.
That's okay. Eleanor, you've got your hand up.
Well, I live in a 120-year-old cottage.
Yep.
And I was thinking you might be going to say something about getting your wiring checked regularly and updated, because I think that's probably the greatest fire risk in this house, is that there's some quite dodgy
Have you done that? Have you done that?
I've done it every 10 years.
So is your fuse board an RCD fuse board's got little switches, or is it removable?
Yeah. Switches.
It's
also
safe,
got a circuit breaker.
Yeah, that's fine. That's what you need. It's good.
The difficulty is, though, it's up at about, I don't know, 6. I can't get at it because I shouldn't be standing on chairs or ladders.
You're right there.
So the difficulty is when I have a power cut, like we had a terrible problem with outages 2 weeks ago. And I was quite impressed that I was getting messages telling me this was a national problem and National Grid would fix it as soon as possible. But the trouble was I couldn't negotiate to see whether the board was working or not, or what. So I don't know what the answer is to that one, but I do think it's important to keep your wiring up to date.
Have you got neighbours that live opposite you?
They're even frailer than I am.
Yeah, no, but have you got neighbours that live opposite you?
Hmm?
Have you got
Yeah,
neighbours?
as I said, they're frailer than I am.
So what I was going to say was you'll probably see their lights come on, or
Oh yes,
you'll
yes,
you'll see
that's
that.
what
So
I
that's a way
watched.
of double checking. So if you look out at your
Mm.
neighbours, if your street lights are on, your neighbours' lights are on, the chances are, and your lights aren't on, then your fuse board is tripped somewhere, and then that's where you need to call. But if their lights aren't on, your fuse board probably hasn't tripped, and you just got to wait for the power to come back on.
And I think another thing I'd suggest is having your candles ready for that moment when
I
you
would
have a
suggest you
national
don't do
outage.
that. I would suggest you have an LED torch or something like that, and not have candles, especially if you live in a 180-year-old house. So LED torches, there's loads of them out there now, and loads of lanterns and that sort of thing. They're far better than they used to be, and they last a lot longer than they used to be, far safer. So go and purchase one of those rather than candles. Candles don't really do that much, and especially if you've got your eyes. I understand you've got eyesight problems, so yeah, an LED torch would be a lot better for you seeing around the property than a candle would be. A lot safer carrying it around as well.
Well, probably, you see, my mistake was not to check the torch as well as the smoke alarms.
You want to get yourself a nice quality LED torch.
You know, I had one, but it wasn't working.
Okay. Note to
I haven't
self,
used
check
it
your
for
torch
so
is working.
long, I suppose.
Yeah.
Anyway, of course, the great warning is the Radstock Methodist Church. Somebody left a candle on one Christmas, and the central part of it, the wooden pews, were burnt down. I think some of you saw last night if you came to the local plan consultation, and the smoke damage was very considerable. So you're right about candles.
Yeah, thank you. Any other questions? I put the referral link in the chat there. That gives you the opportunity to either refer yourself, refer someone else, or if you're an agency and you work with us and your agency code's on there, you can then refer to that as well.
I'd like to make one comment, Luke. Thanks very much for a presentation. It's surprisingly frightening, actually.
It was very good.
Once again, I'm going to ask Alison and co to make sure that link is fed out. We'll also make a point of sending it separately to all the parish clerks in our area as well. They may choose to do something with it to try and encourage it. I'm sure, especially with Tim Warren listening to us, that Baines aren't particularly negligent in what they're doing. We need to get people aware of what Baines should be being told about, rather than Baines going out and begging for information. Yeah. So we will send that out to them, and thank you very much for your presentation.
Brilliant.
Quite all right. Would you like me to send those slides to you as well?
Yep.
Yes.
Yes, please.
Our email,
yes, please.
Our email, whoever emailed me. I can't remember who that was.
Yeah, send them to Alison.
Alison. Cool.
Yeah.
I'll do that, Alison. Excellent.
Thank you. Thank you very much.
Do you mind if I leave you to it?
No, not at all. You've got places to go, for heaven's sake.
Well, I've actually, I'm on call at the moment, so I've booked off just so that I can be with you guys. So I need to put back on. So
yeah.
Luke, right. Thank you very much indeed. Please go now.
Yeah.
Most welcome. Care. Thank you, guys. Take care.
Okay. Bye-bye.
Bye-bye. Bye. Yeah, you carry on.
Okay. I'm now going to welcome Helen Harris, who's there with a very spectacular pair of glasses on. We're very glad to see you.
These are my blue light glasses.
That's right, yeah. Manager of it says here you are the manager of Three Valleys Health Primary Care Network, and you're going to give us an update. So please go ahead.
That's right, thank you. And I've got a beautiful Chew Valley Lake behind me. Didn't look quite like that as I drove back from Radstock this evening. I think Alison's got my slides, haven't you, Alison, that you're going to share for me? And when I attend these meetings, as I have done before, I'm never sure whether you've heard about PCNs or whether what sort of level to pitch everything at. So I've got a few slides at the very beginning that just go back to basics about who we are and what our aims and objectives are, and then finishing with some more tangible evidence of what we're up to. And hopefully you'll find that all interesting. But I'm also very keen to take your questions at the end. So Three Valleys Health Primary Care Network, we are 11 sites across North East Somerset, and that's 9 GP contracts. And as you can see, geography-wise, we're kind of grouped into 3 groups of 3. So we've got Chads, Somerton House and Westfield over that side of the patch, and then Chew, Harptree and St Mary's in Timsbury, and then Elmhays in Poulton, Hope House in Radstock and Hillcrest over in Peasdown St John. So for practical reasons, that's often how we group ourselves, because we're quite a large PCN. And for those of you that know the geography well, it's about 40 minutes edge to edge in the car. We're quite a large PCN. So a bit more information on the next slide about PCNs generally. NHS England and the government decided to invite general practice or GP surgeries to work together at scale way back in July 2019. So I can't believe that we've almost had 5 years of PCN working, which was the original arrangement to sort of test primary care networks for 5 years. There are 1,250 primary care networks in England, and to date, most primary care networks are employing around 25 staff. So to tell you that we're twice the size and we're recruiting over 40 staff means that we're on track. And I think that's a very positive sign for general practice and primary care, is that those additional staff across England are helping with primary care resilience and GP resilience. So that's a big good news story. You can see from the wheels that I've put there, those are the extra roles that we are now seeing in our practice. So we've got a bigger pharmacy team of clinical pharmacists and pharmacy technicians. We've got a team of social prescribers, care coordinators and general practice assistants. We've got first contact practitioners, that's physios. And also we've got a team of physicians associate and nurse associates to support our GP and nursing teams. I think, the wheel on the left there about building strong community links is also really important for us. And it's me coming along to evenings like this and sharing the work that we do, also working closely with Wern and our village agents and all of our third sector partners across North East Somerset. And I think our care coordinators and social prescribers particularly have done a fabulous job at making sure that those networks are stronger than ever. We've also got an on-the-day home visiting nurse practitioner, but I'll talk to you a bit more about that in a moment on the next one of the next slides. Thank you, Sarah. So how big are we? Well, we are 68,000 registered patients, and as I said earlier, that's roughly twice the size of your average primary care network. But I think we decided within our group that it made sense to have all of the practices in North East Somerset, all the rural and semi-rural practices together working under one primary care network. And I think the main thing for us is that it gives us a collective voice, a strong voice. I think previously there were certainly concerns in North East Somerset that we were often considered or felt the poor relations to our colleagues in Bath. So working together like this really gives us that strong voice, and we've built up a good reputation with our integrated Care Board as being a PCN that's interested in working on new trials and pilots within healthcare. And I can give you some examples about those projects in a moment. So we've got an experienced practice manager group that meets weekly. That's kind of the engine room of PCN working. And we've got senior nurse operational groups as well that meet bi-monthly on Teams to make sure that we are at the top of our game in terms of clinical policies and the way that we're working to support our patients. Now, all of that working is now formalised as we've recently become a limited company. So we are now able to directly employ those 40 staff, those 40 PCN colleagues, whereas previously all of those staff were employed by the different member practices. But we formalised that, put that all under one roof, and we're employing those staff in the limited company. All of that is underpinned by a network legal agreement, but for the future, potentially that gives us the opportunity to look at what more flexible ways of working, take commissions for working together more closely in the community. So we're really excited about that. And I won't read out the next few bullets, but within our health system, we've got a number of experts within our PCN that represent Baines, Swindon and Wiltshire on various committees, which is always useful and keeps us abreast of strategic thinking. Thanks, Alison. So what have we done so far? So I think the most high profile programme that we've had is our ongoing and highly successful COVID vaccination programme. We started at the Soma Centre, as many of you will know, back in early 2001. And since then, the programme has developed to practice-based clinics, as the vaccine is now more user-friendly, has got a longer shelf life, and we feel that it's better to run those clinics closer to our patients in our member practices. So that's changed slightly, but we're very much at the forefront of making sure that our patients within the relevant cohorts are protected. We've undertaken a comprehensive review of our practice standard policies and procedures, and basically, we're making sure that we are Care Quality Commission ready for when we are inspected, because practices do get concerned about that, and really have valued the support that my colleagues in the network can give to make sure that we've got one best way for all our policies and procedures. We're very keen to focus on improving patient access initiatives. So for your own registered practice, if you're registered in North East Somerset, that might be some later evenings, some Saturday mornings, and also perhaps some early mornings slots made available to make us as accessible as possible to working parents, to young mums that have to bring their children in for immunisations, etc. So we're really trying to think about when our clinics are available to make sure that that fits people in their busy lifestyles as much as possible. We've just, as I touched on earlier, last November, we have directly employed a home visiting nurse practitioner. His name's Dominic Clare. He's got a fabulous CV. He's very experienced in home visiting. He does weekend shifts at the RUH in their emergency department, so very hands-on and practical. And what he does is to support our doctors with the home visits that we do on a daily basis. So he's got 8 slots per day, and those slots are shared amongst our 9 member practices, and that really has already helped the doctors with their busy day. And we've had some great patient feedback about Dominic's care and attention as well. So he does about 1,000 miles a week. So it's a difficult job for him, and it's quite a lonely role, isn't it? You can imagine home visiting. So we do make sure that he's got lots of support with some regular debriefs and tutorials with a GP that's signed up to give him that support. But that's been working really well. We've organised an additional late afternoon blood specimen collection service, so that patients can not only have bloods taken in the morning and for them to be delivered to the RUH or BRI labs, but we've got now slots available in the afternoon, and then the collection, the car comes round at 6 o'clock in the evening to take those bloods to the lab, to allow us more patient flexibility and extra appointments. We get through a lot of bloods in a week, as you can imagine. And then some more kind of strategic things around young people. So we're really recognising that we need to give our young people some support, and we're trying to forge really strong relationships with the 4 local secondary schools in our area and the many primary schools that feed into that, and understand a bit better about the school nurse team, which I must admit over the years has really been scaled back. There is no, one nurse for one secondary school. They're very much shared roles. So I'm trying to understand that. That's a commissioned service at the moment that is owned by HCRG, formerly Virgin, and really try to make sure that we are better understanding how we can support our young people. So that's kind of work in progress, and I can come back another time to update on that. We're thinking about group consultations and how that can help, and we've got some trial practices that are involved in that. Let me give you some examples. We've got some women's health clinics that have been happening in the evening to talk about HRT and menopause. We've also thought about group consultations for long-term conditions like asthma and diabetes, and these are not only informing patients about the lifestyle changes that can support them, but also getting groups of patients together with the same condition when they consent to do that, so that they can give each other some peer support. And the evidence shows that that's really helpful in tackling some of these long-term conditions and giving patients support that they need. We're really keen to think about lifestyle medicine, things about looking at green prescribing and community projects. I've got some examples of that I can give you on another presentation. Don't think we've got time today, but also I think in terms of how we've developed, and we've got much more on the ground support for patients with their mental health and with their lifestyle changes. And we're calling the social prescribers and care coordinators that we employ Three Valleys Better Health Team. And they, as I said earlier, work together with our community and voluntary groups to really try and support patients on that better health journey. Now, some of you may have heard about the 4 carers events that we've already hosted in our community. Those are events to support carers and to signpost support that might be available within our area, but also just to provide a cup of tea and a chat, not only to our own social prescribers and care coordinators, but to fellow neighbours and residents in their area that are finding themselves in a similar situation. Again, it's about that peer support, isn't it? We've got a PCN website, so I put the details there. I've also got my email address on the beginning of these slides. So as we were saying earlier, I anticipated that all of this will be shared with you. And if any of you would like to get in touch, if you have any questions, please do let me know. So I've got just a couple more to finish up. So next steps for PCN. Well, we're hearing about our budget for next year, government budget. And, with the looming general election, it's no surprise to tell you that our financial year from April is, we anticipate, going to be more or less flatlined. So I'm not expecting to have more budget to be able to recruit extra staff this year. So I think the 40 that we've got in role now will be, and next financial year will be about further developing and supporting those colleagues that are already in a pretty challenging role in primary care. And we are thinking about how we get something new that's called a learning organisation accreditation, which is a kite mark that we would subscribe to. And the intention for that would be, when our budget does increase in future years, we hope, we would be a magnet for attracting, developing and retaining a really strong PCN workforce. So that, I think that for me is one of our key objectives for next year. But always we'll be continuing to identify and develop ways of working to improve our patient and our staff health and well-being. There's been a lot of work in BAINS, I'm sure you're aware, about tackling health inequalities. And we've been thinking about how we do that through our social prescribers, through our strong links with WERN and the village agents. So that's another key principle for us. We'd also like to promote digital. And that's for the patients that want to and can use our technology to help them. I'm thinking, prescription ordering, appointment booking, and also that in turn will help our own operational efficiency and our front desk operations. We're thinking about practice estates. PCNs have really contributed to a problem, really. We've now got to find desks and space for an extra 40 staff. So although we have been able to do that quite easily to date, and that might, include a bit of shared desks, a bit of home working, if we continue to grow at the rate that we want to, then we'll have to think about practice estates and, how we can afford to make sure that everybody's got somewhere to sit and to see patients. We're thinking about greener opportunities, as always. One of the things that I'm looking at the moment is our home visitor. He uses his own petrol car. And I'm thinking about how we could potentially organise an arrangement for him to have a more sustainable vehicle funded by the PCN. And in fact, I've been in touch with Leslie Mansell and Chris Dando. Haven't heard back from them yet because I'm just wanting to explore options. I think you have got some PowerPoints, charging points behind Sainsbury's in Midsummer Norton. So I'm just trying to understand whether we could potentially tap into that and any carpool or car share opportunities for our home visitor who works 8 to 5:30 Monday to Friday. Patient forum, so really keen to make sure that that group grows and flourishes. It's really important that we continue to listen to our patients and also that we ask that group to be champions for us, to share knowledge of the things that we're doing and where we need our patients' help to continue to the future. And then I think next step for the PCN, I put there one voice. So, we recognise that our workload is really challenging at the moment and in its current format, often feels unsustainable. And, we've just heard that we're unlikely to get much of an increase to the global sum, as it's called, that practices get to run their surgeries. So I think that one voice is about us being together and reaching out to government and NHS England about those challenges. And in fact, we are shortly going to be setting up a meeting with Jacob Rees-Mogg to go through some of these challenges with him and to make sure that government understands our financial situation at the moment, so we can keep you posted on that in the future. The final point on there is just about the Pharmacy First offer. So it's not a PCN initiative, but it's something that Community Pharmacy launched at the end of January. And it's a way that they have been trained to better support primary care. So there's a number of things that they can now do, and I think it's 7 things that they can support, ailments that they can support patients with. For example, insect stings, earache, number of other things that they can support directly with. So we can triage patients into community pharmacy, or patients can actually approach them direct. So community pharmacy themselves will be doing a patient communications campaign to let the general public know that they are able to support with those things. I think also some of those pharmacists have been trained and will be signed up to support women with contraceptive advice as well. So that's new. And I think it's just another way that community pharmacy can be an extra pair of hands to help. And we're not saying that we're pushing work that way, but we're just saying we're giving patients extra choice if they would like to go to see their pharmacist instead of their general practice. That's the end of that list. And then I think I wanted to give a final overview on spring boosters. So who would have thought that we are on phase 8 now of our vaccination campaign? This is likely to start from mid-April. And the PCN, our PCN, has been asked by NHS England if we would like to participate. So it's an agreement that we sign up to do it. We've said yes, we will. We want to support our patients. And the JCVI advice is that it will include the following cohorts that I've listed there. So no surprise to you that it's 75s and overs, children or babies more than 6 months that are immunosuppressed, our housebound residents. We've got about 400 of those across our patch, and the care homes for older adults. So we will be doing that from mid-April. It's a lot of extra work for us, but we feel that it's the right thing to do, and we'll keep you all informed about the process for that. But we think it will be the same as the the last few waves that we've had, where you will be invited to go into your own surgery to have that jab. And we've actually been given this time some extra support for some practices who have got a lot of care homes and a lot of housebound. They will be given some system support by our BSW vaccination team to help with some of those vaccines as well. So I think that's it from me. Back to the group for some questions. Eleanor, thank you.
Sorry about this, jumping in with the first question. The first of all, the Pharmacy First question. Of course, at the time when it was launched, the government was making a lot of noise, and I had thought that it was an initiative from central government, actually, so I'm glad you've put me right on that one. But the first Saturday it was available, I think that was more or less the 31st of January, I spent 40 minutes queuing in the pharmacy at Elmtree Avenue in Westfield to get a prescription. And there was a sort of hollow laugh around all the other people queuing up, because they said, well, if we've got a queue like this just to get prescriptions and things, how on earth are they going to manage to do all these extra services as well?
Yeah,
what are we going to do about the shortage of pharmacists and pharmacy assistants? That's the first question. And the second question is Poulton Hospital. Where does that sit in all this, and why isn't it used more for community clinics for, say, diabetics or glaucoma or whatever?
Yeah, oh, those are good questions. So in terms of community pharmacy, I have been having regular meetings with Lisa Fisher, who's our Avon, as it's still called, local pharmacy rep. And she has been saying to me that this Pharmacy First is a national initiative. But you're quite right, Eleanor. Locally, it might not be that every pharmacy is all guns blazing and able to give this extra support. So I think that's what concerns us. What are these patient or general public communications going to look like? Because the last thing we want is for it to be words and figures differ, isn't it? You don't want to raise expectations. And then, as you say, patients are queuing for a prescription, let alone seeing somebody about their earache. So I'm keeping close to what that will look like within our patch. I know we've got, I think it's 7 or 8 community pharmacies within North East Somerset, and I know the names of all of those pharmacists. And as far as I'm aware, they've all undertaken the necessary training to give patient support against those 8 patient group directives, they're called. But in terms of how they actually roll that out, I don't know the answers to that. But yeah, that it's an interesting point, isn't it? I think there's a broader point that you've made there about training and resources for the future. And I do know that Bath University, they have got a really strong cohort of trainee clinical pharmacists. And the course, as I understand it, has changed so that now when they qualify and they're straight out of uni, they are already prescribers. They can prescribe medication. So, you know, that makes the whole situation a lot easier. Now what happens is clinical pharmacists used to come out of university and have to then undertake a separate prescribing course, which, you know, often took many years if they were doing that on a you know, part-time basis. So I think people will be coming out of university better qualified, and we should see those numbers increase within community pharmacy to be able to support this offer. But it's to be seen, isn't it? Shall I take Lavinia? Have you got a related question?
Please. Yes. Can I just say to everybody, Lavinia, before you start, you'll notice that on our agenda, our time limit really for this was set at 7:25, which is now. I'd be very grateful if you could bear with us, because we have another presentation after this, which is particularly important as well. So please bear with us on the time there. Okay, Lavinia, please carry on.
Thank you, Ron. Just wanted to make a point to you, Helen, that in Radstock at the weekend, there is no pharmacy provision whatsoever. We just have a Monday to Friday service. And I mean, it does affect residents, and it's well documented that we have difficulties with public transport. So trying to get to a pharmacy, either in Peasdown or Midsummer Norton, for example, it can be virtually impossible for some residents.
Yes.
And of course, that may be their only opportunity anyway, if they are working during the week. So yes, it's very, very well. I know it's a complex.
Yes, it is. It is. Yeah, but you know, I think that really highlights the challenges of our rural network, doesn't it? You know, those are really very real issues to our patients. And Eleanor, just to pick up on your second point about Poulton. As you know, that they run a minor injuries unit within Poulton, which I think has been stretched, to say the least, through winter pressures. But I do meet with them, the leaders of the MIU, on a bi-monthly basis with our senior nurse team. So once again, we're trying to build better links to understand how they can help us in primary care and the sorts of things that they can help our patients with. But I must admit, I do not have an answer on what's happening with the rest of Poulton. You know, I know that there are some services in there that are run by HCRG, but I think, you know, the GPs within our group do feel that that's a potential opportunity. You know, there are spaces within that hospital, aren't there, to be running, as you say, local clinics, outreach clinics, to save our patients having to travel into hospital.
Okay, Lavinia, are you still got your hand up? Is that had you not finished your question? You're muted. You're muted, Lavinia.
I'm so sorry. I'm just typing on the chat actually to say that I'm really sorry, everyone, but I'm going to have to leave the meeting now. I have another commitment. But thank you very much indeed for your presentation, Helen. That was really interesting.
You're welcome. Thank you.
No other questions for Helen? I'd just like to make a couple of comments. I thank you very much for your presentation, Helen. To be honest, at times it's horrific. We look at overstretched facilities, and we put out some facts and say 69,000 potential patients, and a home visit nurse that's capable of this. It's only possible to give 8 visits a day, and he works from 8 till 5:30. So the level of overstretching and overcommitment is just beyond belief.
Well,
know there are
don't
other- I know there are
don't
other-
forget he doesn't just do all of the home visiting provision.
No,
That's
I
an
understand that.
extra layer
So-
of support for the doctors. But yes,
Yeah.
it's a lot of patience, isn't it? Yeah.
So there we go. So thank you very much indeed for your presentation, and we look forward to hearing you at subsequent meetings, actually, because you've got a lot to say. Thank you very much.
Thank you.
Okay, so now we're going to welcome Tim Rawlings, who's the project manager for the Active Way, and Gilly Edwards, who's going to talk with him. So over to you, gang.
Lovely. Well, thank you very much, and thank you, Helen, as well, because obviously we're working very closely with your team and the Better Health team down there in referring patients and people through to our activities. So obviously I'm quite very aware of the time. I've got a presentation provided here, but what I'll do is I'll just share my screen quickly just so we can go through it. But what I'll try and probably buzz over a lot of it, just because I did come back in October just to present where we were, but obviously what I'm really keen to do is provide a bit of an update of what's been going on. We've been making huge progress over the last few months, which has been really encouraging. So those of you who don't know, we're the Active Way. So we're the Bath North East Somerset Council's Active Travel Social Prescribing project that's been funded from Active Travel England. We received a grant fund last November, November 22, to look at a pilot project working in the Somer Valley and how we can really promote social prescribing to a range of active travel activities. We're having a broad offer for walking, cycling and wheeling. And really that is to sort of create confidence, motivation, drive knowledge and skills. Particularly keen on sort of finding some really good positive outcomes through those interventions, looking at improved health and well-being and reduced hospital and GP visits, in particular from some really key cohorts. So that on the screen there is just a really good list, comprehensive list of the things that we're trying to sort of very ambitiously deliver over the next year or so, and beyond, we hope. But I can see actually in the meeting today we've also got Marjorie, we've got Judith there as well, so who are involved in some of our interventions also, as well as Gilly, of course. But a huge amount of free activities that we can offer in terms of interventions for vast number of people. Pretty much there's something for everybody there, really. Obviously working with local stakeholders and partners also. But I'll leave that there as it was. But it's all on our website, and I'm happy obviously come and talk to anybody that wants to listen to me to understand a bit more of it. But really what we're trying to do is obviously through those interventions is help people with in particular targeted areas. So certainly those in with sort of from health inequalities in deprived areas, those with long-term conditions, underrepresented groups, ethnic minorities. But yeah, really, we've got such a broad spectrum of an offer here that there is really something for everybody. So we'd welcome any referrals from across the systems, really. So we've done a huge amount over the last year. So even since September, I think we've seen a huge progress. But from having staff in place, we've developed the referral management systems that we've partnered with the Community Wellbeing Hub. We've developed our own mini hub, so we've got that system in place that makes a real sort of one-stop shop for all of our interventions that we've got going. We've got a public website where people can access all of our information from as well. We've got storage space full of e-bikes and pedal bikes to help Marjorie and her team at Sustrans to deliver some cycling activities, as well as putting on the networks as a sort of a public hire scheme. And we've recently awarded all the projects for the Wilson grant, which was just going live as I came to the last presentation I gave to you back in September. So since then, really, I think back in September we're really just starting to get going. So we've had a huge uptake really since then, and the way I look at it is we've not done a huge amount of proactive engagement. We've really relied on Helen and her team there to go out and prescribe into our activities as kind of as organically as possible. We've just started and got our projects in post from late September, so we're now in a position to go out and sit with groups and community groups in their space and try and get referrals in directly and far more proactively. But that said, we've had over 4,000 people take part and beat the streets. We've had 60 individuals be referred through to our hub, and that they've stretched across about 120 different referrals through different providers and activities. We're working with Key Active, who are a digital behaviour change intervention, and we've had 400 participants directly referred through from GP letters and notifications, and that's a really positive uptake from across several practices in the Somer Valley. And we're having some really good testament and some really good comments coming back now. I know Key Active, I've just seen actually before I joined you that they've had their first sort of cohorts have finished and they've got some really good feedback already. But we're learning some really steep lessons over this period, and we know that the referrals are best, and strongest when they're done on a one-to-one conversational basis. Every patient that's come through the referral system has needed that conversation and that guidance in supporting to get onto an activity. We're trying to meet a huge number of needs, and obviously by that we have to be as flexible as possible. A lot of the cohorts that we're trying to engage with aren't always committing straight up, so we have to do a lot of persuasive work to get people onto those bikes, onto those cohorts, as Marjorie and Julia will testament. You can ring and phone and leave letters as much as you can do, but until somebody actually comes to you, it's very hard to get that commitment. So we're working very hard to set up those systems and make it as easy, and share some testimony and work a lot more on that engagement front to make sure people are aware and confident in what we're delivering. We're also very realistic that actually a lot of the referrals are coming from a handful of people, so we need to work much harder in our referral networks and our partners there to make sure that it's clear that this is for everybody, and that's a very easy process to go for it. But I think that comes from our engagement. We're finding that more referrals that are coming our way, the more it's generating, more demand it's generating too. So we're confident that's sort of going to start snowballing fairly soon, and we know there's been a huge amount of sort of upswelling, as it were, from some of the interventions and testimonies that we've got coming back already. So this just illustrates really the split of where we're seeing the bulk of our referrals, really. As you see, it's all across the board. So all of our activities and our interventions are on the Community Wellbeing Hub and our mini hub, and here they can be referred into these particular pods, as we call them. But that really goes to show the sort of the split and the range of the activities that we've been able to put on over the last few months, really. So it's they're landing in every pod, I suppose, is the example there, which is we're really keen and really excited to see. So following the last meeting, we went out for the Wilson grant, and we're really pleased to say that we've awarded 10 projects and funding to get going. And they range from sort of obviously active travel, but also there's our arts trails, there's cultural projects, there's as you can see, there's a list in there. So we've got a side-by-side chatty cycle, so a sort of well-being taxi service. Inclusive Fit is a group that meet to try and get people ready to run the park run and develop cohorts through that. We've got women's creative revolutionaries who are developing things like benches and planters for the greenway and other areas that we can create really good enticing walking spaces and nature trails. Working with the town council with the Greenway Arts Trail, so that will hopefully come out later in the year. So we're really excited about the range and breadth of the projects that are being delivered through the Wilson grant, and we hope that, well, we will be going out again later this year for another round of funding too. So we want to learn as much as we can from this round, what's worked best, how we might want to promote them in specific areas, and see what more we can generate from that grant. So there's lots to be excited about in terms of what that's going to bring for the area too. So what's next really is we're really focusing on our engagements and being as proactive as we can do. So a call that I think I made last time stands again this time, that if there are any opportunities for us to come along, sit with participants, with patients, with people that may benefit from the support that we can provide, then we're really keen to come along and literally sit there with our tablets or our leaflets and get people signed up where we can do. It's a very simple system, it's all free, and we're really keen to get learning as best we can do. And the only way we can do that is to get people out there doing it. We're starting a process evaluation in April with our monitoring evaluation partner at the University of West of England. So from that, we really hope that we can learn how's best we've been delivering, how's best to pivot and change that plan if it's not working quite so well in some areas. But I think from what we're seeing already, we've got a lot to learn on and draw on and really evidence and shout about how well it's gone and what that demand is and what it might look like moving forward as well. But obviously we're really keen. We can't stop here. We've got a huge more promotion to be doing. We need to be far more visible to the community to make sure we're attending all the regular events, and we'll be as prominent as we can be over the coming year in the community. I think you saw in the chat there, Becky from the Third Sector group is there, who's just gone out to a further social prescribing project manager. So we're really keen to establish a social prescribing vision and framework for BANES. And we really like to highlight, obviously, the example we're setting with the work we're doing with Helen's team at a Better Health team, that the system that we've got in place through the Community Wellbeing Hub and how that can connect, the health professionals, with the organisations, with the participants, and how that can be replicated and shared across other systems too. But ultimately, for us, it's about breaking down those barriers, making access for all essentially into active travel, be that building strength, confidence, giving people the resources and the means to be able to do it, and empower themselves to actually feel that they make a difference for themselves, really. So the really whistle stop tour, as I said, I've got far more detail that I can share over over either in a presentation or via a website, but I'm happy to come and meet with anybody I can. But what I'd really want to do is welcome Gilly from Supporting Family Change to give a bit of an example of one of our providers and what impact they're making. I think Gilly's got a bit of a case study she can present as well. But so Gilly, I'll let you introduce yourself. I'll just stop sharing now so you can talk. But certainly have some questions at the
Hi
end of this time
everyone.
as well.
Hopefully you can hear me okay. My internet connection's not always fantastic at home, and I'm also very conscious that I'm the last act of the evening, so I won't take up too much of your time. But as Tim said, I'm the fundraiser for Supporting Family Change. Some of you may have heard of us, or you may have seen us in our red outfits around Midsomer Norton and Radstock area and around the Somer Valley, or our branded vans. And if you say it very quickly, Supporting Family Change sounds like supporting family change, and that's exactly kind of what we do. It's about supporting local families to make positive changes to lifestyle, whether that's through improvement of physical health or emotional health and well-being as well. We're based out at the New Rock Estate in Chilcompton, so we're in the area where most of you are, well, all of you are operating, and we work with people of all ages as well. So we go, I think our youngest person that we support is 4 years old and the oldest is mid-80s. So yeah, a whole range of age groups. And I'm sure some of you know what we do, and I know that some of you don't. So I'll just give you a quick whistle-stop tour of what we do. So we run a mentoring service for children and young people. That's primary school as well as secondary school, usually on a one-to-one basis, or if children or young people are extremely vulnerable, it's a 2-to-1 basis. And those children may have an educational health care plan. They may be vulnerable, they may have experienced trauma or have emotional or behavioural issues to deal with. So we are recognised as an alternative provider to schools in Bath and North East Somerset and in Wiltshire as well. So for both those authorities, we work with their young people. Last year we set up at our premises in Chilcompton, we opened a women's wellbeing centre because we were very conscious that women, you know, they're kind of, dare I say it, the glue of society and the glue of the family, and very often if you can support them, you can have a ripple effect out to supporting the kind of extended family and the rest of the family as well. We provide free activities for families, sometimes during the holidays as well. So we'll offer multi-sports days, etc. And that's throughout Bath and North East Somerset we operate. So last summer we had a kind of family fun day up at Odd Down cycle track as well. So that enabled families to engage with us there. We run something called a Love Yourself programme, which is supporting teenage girls into having more self-confidence, dealing with a lot of the issues that they face, whether that's around anxiety, confidence, also girls that aren't in education or in school, so supporting them. And we also run a fully inclusive football club on a Monday afternoon / evening at Midsomer Norton Sports Centre. And again, we have young people or children about age 8, and then the oldest participant is a gentleman who has early onset dementia, and he's about 65. And everyone it's a sort of open sports session between 4 and 5. on a Monday. So a lot of the activities that we offer are not scheduled in. So it's not like turn up on a Tuesday. They're very bespoke according to the referrals that we receive. So we work very closely with social prescribers, as Tim said. We also work with PCNs. And during COVID, when we couldn't deliver sporting activities, we started walking with people because you could do it socially distanced, which is how we got into walking, really. And as Tim said, we are part of the Active Way and receive referrals in for that. I think our learning that I would say from it is that originally we thought we would be running sort of small walking groups, but what we found with the people who are being referred to us is there's a sort of they're further back in their confidence than we envisaged. So a lot of people aren't confident enough to just join a group. They're quite isolated. They want to be or they need to be emotionally supported. So it starts off as kind of one-to-one walking usually, and that opens up all sorts of opportunities because you're with an independent adult where you can confide in them about any issues that you might have. In fact, today I was out walking with an 80-year-old. Well, she celebrates her 80th birthday tomorrow, and she lives alone. And so for her, a lot of things that are quite small, probably for us, become very big for her because she doesn't have anyone to talk things through with in the evenings, and she is on her own. And so as much as the walking is great, it's the social contact and the conversation that is just so vital for her. And then after we've been for a walk, we did about 6,000 steps, I think, around Lytton Lakes, well, Lytton Reservoir actually today. And then we just go and have a cup of tea and then take her home. And that for her is huge. And she said to me today, you'd have no idea what impact you've had on my life and how valuable this is, which is lovely. And I was just going to give you a brief case study of another lady that one of my colleagues has been seeing since December, referred through the Active Way. And she lacked the confidence. Again, a lot of this is around confidence. And she was worried she was going to fall. And she therefore wouldn't go out on her own at all. And she didn't have others who were available to go out with her. She's only late 30s. She'd been in and out of hospital for several reasons. When she was young, she'd taken quite a few steroids, so she was very conscious that she was also overweight, or she'd put on weight. And so over the course of time, so we've been walking with her once a week, and the distance has increased and the intensity and the speed has increased, and her fitness has improved, which is fantastic. But very often we find it's just baby steps. So it's sort of like, right, we're going to walk half a mile, or we're going to go around the block. And then it's like, right, now we're going to try and get to a mile. And we try and ask the people that we support to set their own personal targets, giving them the choice of kind of how far they want to go, but obviously being a bit of a challenge. So this particular lady has said she'd like to walk the Bath Skyline, which for those of you who've walked it, know that it's not the easiest of things to do, and it's about 13.5 kilometers, I think. So that is her target, and she wants to do that in the summer when the weather is better. So hopefully that's what we're building up to, for her to be able to achieve that. And it's things like that that just are huge steps for people, and once they've achieved one target, they then become far more willing to try even bigger ones. It's been great working with Active Way because I think it's just clarified, and we've been able to meet other partners who are also part of that process. And I think I'll stop now if anyone has any questions, because I'm conscious of time.
Thank you very much. Any questions from anybody? Tim Warren. Tim, please.
Hi, Tim. Hi, Gilly. Just
Hi.
a very quick one. A few years ago now, we did a little trip up to Birmingham, and a similar kind of thing. They're all doing Tai Chi, and it was quite good because A, it's good for your fitness, and B, there was a lot of people there, and C, it's quite cheap. And I think it was quite good, A, for the fitness, but also there's a lot of people that were suffering from perhaps loneliness, and it just gave them something to look forward to every week. You know, we're going to Tai Chi on a Tuesday, and they're a bit upset with us because we were half an hour late because of them, or they had to change the day or something. And that's the high point of the week. So it might be worth something it's worth looking into, because it's a lot of people and cheap as well, which always helps.
Yes, you're absolutely right, Tim. And we have actually run a Tai Chi course from our Women's Wellbeing Centre. In fact, we were very lucky to find a local Tai Chi teacher who was very reasonable. And we also run a project, again, excuse the name, it's called the BRAS Project. And it's for women, and it stands for Believe, Reach, Achieve, Succeed. So there is a reason why we've called it BRAS. And we offered Tai Chi and also Pilates, and then each kind of term women choose different activities that they want to do. Some of them aren't sport related, so at the moment they were doing singing, and so we formed a choir, so they did that. But we're going back to Pilates again. So as you say, I agree with you, it's gentle exercise, increases mobility, and also enables people to make other friends and engage with each other.
And I think just to add to that, I think it's, yeah, absolutely, Gillian and Tim, I think you're right. I think it's finding those opportunities that people can feel that they're making a difference for themselves. And that's why that centered sort of one-to-one approach that we want to put in place, that very personalized sort of service, supportive service that we can do, is find those opportunities for people that might not fit into the category of, or they want to take part in some of the interventions that we're offering already. And I think once they start with one opportunity, they quite often grow the confidence to want to do more. So we want to obviously target. Yeah. So I think it's just making sure that that's there, and obviously that provides that foundation and that sort of definition of what social prescribing could be and means. So it's around finding all sorts of opportunities that help people in the community. And I think it's about forming those bonds and those social networks, as well as providing that activity sort of by stealth in a way. You know, before they know it, they're doing Tai Chi, or they're going for a walk, or they're cycling. You know, it's a really positive move.
Yeah, it's a very
So Judith,
just very briefly, I'd just like to endorse at the Children's Centre we are partnering with the Active Way, which is really positive. My battery's just told me it's about to die, so apologies. But also the partnership with Hope House Surgery as well, thinking about Helen's talk, and being in the same location and getting referrals from social prescribers. It's just really great, actually, that we're all in this together for the same outcomes, really.
No, we ran our first plug-in walk associated with us this morning, wasn't it, Judith? And it went really well. So
yesterday morning,
people sign up. I think. Oh, yesterday. Sorry.
Yes, yesterday. We've done a whole day.
But what I was so pleased to see when I tuned in is actually how many people we are connecting with, you know, in this forum alone. And I think it's really testament to the partnership working that we're trying to do. We're all trying to strive in the same direction. So I think it's really positive. But
yeah. Well, okay. Have we got any more questions? Over to you then.
Yeah, well, thank you very much, Gillian, Timothy, for coming and telling us what you've done, because I mean, I don't know, perhaps everyone else knows, but I didn't know about it. So it's really great. Thank you. Okay, then, so we're winding up now, and just wanted to let you know that for the June meeting, what we're hoping to arrange is a visit to Sulis Hospital. So the idea is it's an opportunity for them to showcase what they do there. And I think that would be great. It would be combined with an opportunity to chat and have a network and a bit of a summer social, which would be great. So if everybody could let us know what you think, or would you prefer a traditional forum meeting? It would be nice to get back to being a bit face-to-face periodically, wouldn't it? I just love that. So please feedback to Alison and Sarah and let us know about that. And the dates of the next meetings, the 12th of June and the 11th of September. Okay, 12th of June, 11th of September. And where they will be, we haven't as yet made a final decision. So we'll let you all know a bit nearer the dates. So thank you very much for coming. and have a safe journey home. Oh, I suppose lots of you are at home, are you? Yeah. But those of you who aren't, just take care, please, and we'll see you again soon. Cheers then. Okay.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Thank you very much. Thank you all.
Bye.